Good afternoon, and thank you for attending this event with us. I'm Dan Zismer, Director of the MHA and Executive Studies Programs. On behalf of the faculty and staff, we extend our warm welcome. This event this evening is being put on with the partnership of the Alumni Association and ACHE. As you'll see as we move through this, the Alumni Association plays a very important part in the program and what we do as a program. This symposium is named for James A. Hamilton, the founder of our program. We do an event like this every 2 years, and we're taking a little different approach to tonight's event, and that'll become evident here as we move forward with the program. The symposium is 2 years in the making, with preparatory work done in collaboration with Howard Peterson, MHA program alumnus and president of TRG Healthcare Consulting, Philadelphia, Pennsylvania. Howard's also one of our panelists this evening. And Jerry Nye. Jerry, you're here. Would you please raise your hand? And Jerry Nye, an MHA program alumnus as well, and Vice President of C-Suite Resources in Minneapolis. So special thanks to Howard and Jerry for being partners on this project. They both did a fair amount of work in preparing for this tonight. Before I proceed with the presentation and our panelists, I'd like to introduce a distinguished alum as well, and board chair of the Alumni Association, Mark Dixon. Mark's going to come up and give you a warm welcome on behalf of the Alumni Association. So Mark, the podium's yours.
Good evening. It's wonderful to have you all here tonight. How timely this is when healthcare is right in the center of our national debate around the presidential election. I really want to extend a hearty welcome to everybody in the room to this symposium. You know, we used to have the Alumni Institutes many years, and they were really a wonderful way to bring together our alumnus, to bring together thought leaders from around the United States to help us really say, how can we lead better? How can we create a better health system for tomorrow? And it's so nice to see this come back. I want to thank the same folks that Dan did to say, how can we continue this rich tradition? We're fortunate to have Dr. Zismer as our program director. We're fortunate to have engaged alumni who served as part of the interview panel and also the panelists for us tonight. And we're also fortunate to have so many alumnus who contributed both their time and their resources to make this program the best ever. Healthcare is at a very interesting time in this country right now. We need leadership more now than ever. So it's good to see all of you here. Thank you very much for coming, and enjoy the program tonight. Thank you.
Thank you, Mark. I am proud to call Mark a friend. We've had the pleasure of working together in a number of settings over the years, and Mark's a stellar example of volunteerism and dedication to the Alumni Association and our program. So thanks very much for all you do, Mark. I'd also like to thank a number of other people who were instrumental in making this happen. This is a difficult event to plan and put on, so I'd like to thank Mark Raitan, Executive Director of the Alumni Association. Mark, you're there? Raise your hand. He's in the back. Marissa Conrad, staff member for the Alumni Association. I know Marissa is here. Barb Ehlers, another staff member from the Alumni Association. Janet Duff, Executive Studies Program staff. Janet, are you here? Raise your hand if you are, please. Mona Rath, MHA staff and School of Public Health staff. And all the volunteer interviewees who participated from long distances tonight. I'll explain how that participation worked as we move through. I'd also like to recognize some distinguished guests here this evening. John Finnegan, Dean of the School of Public Health. Dean Finnegan, you're here somewhere. Would you raise your hand for us, please? Thanks for attending. And the Honorable John Frobenius, Regent, University of Minnesota, and MHA alumnus. Hi, John. Thanks for coming. And the head of our division, Dr. Ira Moscovici. Where are you, Ira? I know you're here as well. thanks for coming. So now on to our approach and on to the panel and on to the debate. I understand there's another debate going on this evening. This one will overshadow that and perhaps be a lot more interesting, or at least we're going to try. So what did we do? Howard Peterson, who is also, as I said, a panelist, Jerry Nye and I collaborated starting about a year and a half ago to create a list of what we thought represented some of the more challenging questions facing U.S. healthcare leaders, questions that we thought went beyond the mundane, sort of beyond the typical, what do you think about healthcare reform, and what do you think about healthcare costs, and what do you think about Medicare? So we did our best to try to put together a list of tough questions. Each of us then identified a list of CEOs and senior healthcare leaders from health systems around the country, literally from coast to coast, of varying sizes ranging to in excess of $8 billion a year of annual revenue. And each of us contacted those folks with our interview questions. For this phase of the project, and I'll give you the second phase of the project here in a moment, we have the information on about 27 of those participants who either did the face-to-face telephone interviews or dictated responses to our questions. What we have done for this evening is that we've extracted about a dozen of the, we think, the most pithy questions of the survey. We put together a brief summary, each one of those questions, and this brief summary will be presented to each of our panelists for response. By the end of December, we expect to have all of the responses in, and we will work together to put a paper together and make that paper available to the public. We will be videotaping these proceedings for our website, for use by our students, and for availability to our alumni around the world. So as a process, I will be putting a question to a panelist together with a summary of the responses that we received, sort of a subjective summary. And each one will respond, and all panelists are then invited to step in and respond as well. We will not this evening be entertaining questions from the attendees. And as I said, we'll be videotaping this. Panel members, please accept our thanks for taking the time and the effort to do this. Nobody turned me down for this. And I wanted to put together, and think I succeeded in bringing together a distinguished panel of experts in healthcare leadership and healthcare management from around the country. I will introduce the panelists now in no particular order. First, Javon Bay. Javon Bay is CEO of Mercy Health System, Janesville, Wisconsin. And if you heard the last, or the vice presidential debate, you'll know that one of the vice presidential candidates was born in his hospital. So I think he actually got a plug-in for that. And as I recall, it appeared on Saturday Night Live as well. So Javon, thank you. Well placed and well played. Second, Dr. Bobby Daniels. Dr. Bobby Daniels is a practicing physician and CEO of University of Minnesota Physicians here on our campus. So, Bobby, thank you for your willingness to serve on the panel. Third, a newcomer to the Twin Cities healthcare scene, but not a newcomer to healthcare. I've had the pleasure of working with organizations that she's been a leader of in the past, and it is Catherine Correa, the CEO of Health East, St. Paul, Minnesota. So, Catherine, welcome to the panel, welcome to Minnesota, and welcome to the Twin Cities. We're happy to have you here. Next, Howard Peterson, one of our partners in this effort. Howard is an alumnus of the program as well, as I mentioned, and CEO of TRG Healthcare in Philadelphia, Pennsylvania. Howard has the interesting position of advising a number of CEOs of very large health systems around the country, and put together the questions with me and spent hundreds of hours in work on this, as did Jerry and I. So again, special thanks for that. And last, Ken Paulus, another program alumnus and CEO, Allina Health in the Twin Cities here. So on behalf of all the attendees and myself and our program, thanks for spending the evening with us tonight. So I will present a question, as I said, to each of them. I will give a little short summary of what I thought I heard the respondents say. I will ask for their reaction to that, and then I would certainly invite all panelists to dive into each of the questions on the table. If without further ado, we will move to the panel. Question number one will go to Catherine, and again, welcome to the Twin Cities. While leaders surveyed differed on their perspectives and potential approach to healthcare reform under scenarios of Obama or Romney, few argued that reform in some form continues due to the compelling economics facing healthcare in the U.S. Do you agree that healthcare reform moves forward irrespective of who's in the White House? And do you think healthcare reform, as you see it, is going to be positive or negative for the health system that you lead? In other words, will the efforts and effects of healthcare reform, as you expect them to play out, affect your organization, and what do you think you're going to do about it?
And how much time?
You have about a minute and a half, and then we move to the next.
So I would say I hope that healthcare reform continues. I think we all know that the current system is pretty dysfunctional. So when you take a look at what we need to do, access to healthcare is a major issue, as well as paying for value. And so to the extent that the current reform helps us move ahead, even if it is overly complex and difficult to sometimes understand, I would say I'm absolutely for it. Relative to how that helps, then I think we need to step back and say what's best for our community more so than what's best for our own organization. I think that my organization, Health East, is well positioned, a community-based organization with primary and secondary care is all about that continuation, that continuum of care. So I think we get ready for it by doing what we should have been doing all along, and that's reducing costs and increasing quality.
So the rest of the panelists, healthcare reform, good or bad?
You want me to jump in? First of all, I just want to say, talking with Dean Finnegan before we started, I was amazed at how he thinks so similarly to Paul Ryan. Dean Finnegan and Paul Ryan think very much the same. I'm sure that John's happy to hear about that. But John actually made the same comment to me. Paul being from Janesville, we've had a chance for the last 14 years to talk often. And Paul has always said to me the same thing that Dean Finnegan said to me earlier, and that is that with the baby boom generation moving into the Medicare years, there isn't a big enough generation behind the baby boomers to be able to really continue to support Medicare in its current form. And that's why he's advocating to keep Medicare in its current form for everybody over 50 and then change it for under 50 and offer alternatives. So we know that even if the Republicans get elected, healthcare reform is going to stay. But the other thing that people may not know that Paul has shared with me is that there's a number of aspects of Obamacare that he really likes and supports. Number one that he likes the most is the concept of providers delivering care through accountable care organizations, ACOs. He believes strongly, as he says members of the House Budget Committee believe, is that the healthcare system is way too pluralistic, too duplicative, and that there's been strong efficiencies that have been shown when physicians and hospitals and all the other healthcare providers are integrated in one organization, preferably with the ability to manage care on their own, or at least a close relationship with an organization that's very effective and has the infrastructure for managing care. So how do they propose to do that? Well, they want to reduce costs. They know they're probably not going to be very effective if the healthcare delivery system stays the way it is. And so in time, and I say in time because I think it'll take a long time, and sometimes CEOs react too quickly, they kind of create self-fulfilling prophecies. You know, for those of you that are really old, I remember Medicare being talked about in the, or not Medicare, but DRGs in the 70s. And Medicare really didn't start with DRGs until '83, and we didn't see the first commercial DRG contracts until the early 90s. So it takes a long time for these, quote, government regulations to really work their way through the healthcare system, which gives providers a time to react. But what Paul has told me as a foreshadowing is that they are going to reimburse through bundled payments, and that those bundled payments are not going to support all these separate cost structures. So you got the separate cost structures of the hospitals, all these doctors' offices, insurance companies, and that's why I think providers looking long-term, CEOs and others would say, trying to form an ACO via simply contracting with each other probably isn't going to get the job done ultimately. It's going to take the efficiencies that come through being able to combine those cost structures into one integrated organization. So.
Any panelists look forward to the health care reform bill as it's passed, the law, and say, gee, I hope that doesn't happen? Ken?
You know, does it happen or not? That's a different question. I guess what I would say, Dan, just to be a little contrarian, I do think it was a missed opportunity with reform. And if I had to wave the magic wand, you could change a few things. One, I would have it be a lot less bureaucratic. It's very complicated, and a lot of stimulus dollars for things that we probably shouldn't be spending money on. Two, if there's something I like about it, it's the universal coverage. I think that's a good idea. Ultimately, that should be less expensive over time. But I think the two major misses are, first, the incentives haven't really changed. So we're going to cover everybody. We're still fee-for-service for the most part, and the costs will just spiral out of control. And there will be a day when that's going to come home and roost, and we're going to have to deal with it. And we're going to have to make a massive change from fee-for-service to some other payment approach. And until we do, I think we're going to have a major problem. The second thing I'd say is this was financing reform. It wasn't healthcare reform. So nowhere in this conversation was there any consideration of a doctor-patient relationship. And that's the business we're in. So it got reform all around the edges of, you know, how we cover folks and, you know, ACOs and all that, but we never talked about that critical relationship. So I think it's directionally correct. We have to do something. I would love it to be less complicated, incentives more aligned with outcomes and cost reduction, and much more sensitive to patients and caregivers, because that's where the action is.
Thank you. Let me switch gears. Perhaps we'll come back to healthcare reform, given the nature of the topic. But let me switch gears on you a little bit, and let's go to the financial side of things. And I'm going to direct this question to Javon. As we did the surveys, leaders of health systems generating in excess of $5 billion a year in revenue wondered if they were big enough. The question is not, is your organization big enough? That's not the issue on the table. The question that really rings loudly now is, how do you know? You know, what organizational, strategic, clinical, program, or financial markers matter when you're addressing the question of whether your health system is big enough?
Yeah, I think once you know how many angels can dance on the head of a pin, then you probably have the answer to that question, in the sense that you're probably ultimately going to know the answer to that question in retrospect if healthcare reform, and right now its law, gets fully, completely implemented. But I'm glad that, Dan, that you said it's not size, are you big enough in terms of revenue or dollars, because I was just visiting with the CEO of 12 very large hospitals in the Chicago, Illinois area, and she came to me saying, you know, can you help me, because what I've got here are 12 big boxes. And I realized that that's all they are, 12 boxes. We're not really in control of the revenue coming to us. We're dependent upon physicians outside of ourselves, to decide to send us referrals as they develop their own referral sources or their own revenue sources wherever they can, in ancillaries and bigger diagnostics. And obviously, the inpatient volumes are dropping. And what I need to do is to build some kind of independent revenue sources where we are in control more of our certainly our entry-level revenue, because all patient care begins in the physician's office, except for the emergency room. And from there, it goes to the inpatient bed, it goes into the OR, it goes into post-acute care, wherever it's directed to. And obviously, you've all heard that statement that the most expensive piece of technology in healthcare is the pen in the physician's hand. And so that's true. And Milliman Robinson out of Milwaukee says that I had him the Milliman Robinson people meet with all 400 of our multi-specialists, and they stood up and they said, we're here to tell you right now that 70% of all the care you deliver is unnecessary. And of course, we got quite a reaction from our physicians in the room. So we have a long way to go in learning how to really deliver the appropriate care in the appropriate setting. And but I do think that, again, we're fee-for-service now, and we will be, but we'll be migrating off of that. That's in Obamacare. It's also in the Republicans' plan through more bundled payments, truly more at risk. We've had the advantage of we've got about 18% of our entire business is fully capitated through our own Mercy Care insurance company, through Medicare Advantage, our Medicare Advantage product with a certain population of Medicare patients, and with the state of Wisconsin for Badger Care. So I consider it very valuable that we're able to start to work with our physicians on engaging them to learn how to develop physician order sets, protocols, and respond to those in order to get the excess care eliminated. So I guess what I would say in terms of are you big enough, the question would come down to is, are you in control, your organization in control of enough of your revenue to support yourself, where you're not dependent upon somebody else to send you that revenue? And if you are, do you have a strong enough access, presence of your system within your marketplace, however large that is, to be able to get your fair share? And then lastly, once you get your fair share and being able to control enough of the revenue coming to you, can you manage it? Can you manage it effectively? The last point I'll make is, having 26 years ago being part of what was then the largest horizontal hospital system in the United States, I learned very quickly that when you talk about a $5 or $8 billion system that's diverse across the country, if you try to offer administration from a central corporate location and central policies to all those various entities in various locations around the country, it just doesn't work, because healthcare ultimately is local. Every marketplace is local. It has its own characteristics, and it has to be offered local. And so I was reading some of the feedbacks, and I would say that you're big enough if you, in whatever market you're in, if you have ultimately enough control, independence over your revenue, what you need to sustain yourself, and to be able to get your fair share of the market and to be able to manage it. That's my quick reaction.
Howard, you have an interesting vantage point because you work with health system leaders around the country that are considering consolidation, merger, acquisition, and I got to believe a lot of that's being driven by a perspective that we're not big enough, we're going to have to roll up into a bigger system. What are you seeing?
Well, I think we tend to think about this too simplistically, that we think about the world as combinations of, you stealing your term, boxes that we've assembled. And I do think that revenue size is important for a couple of things. There are economies of scale, as you all know too well, in information technology that you're just never going to get. and in smaller settings. And one of the biggest issues facing us is the transition from fee-for-service to being paid another way. That's going to require a lot of money on somebody's balance sheet, and trying to do that on a small scale is a difficult thing. But I don't think it's a monetary issue. I think it's primarily an issue of geographic coverage and access over a sufficient population. If you've got access, you've got the components of delivery, you've got a sufficient population, you control that. I think that's a far better definition than simply revenue size. And I'll just make one last reference. What we do when we merge is if we're taking two hospitals, we put them together, and the great idea is that we're going to get efficiencies by putting the back office operations. That's just too small a thinking. We have to start thinking like the banking industry that says, no, when we put two hospitals together, we ought to move all of the transactional work to South Dakota and do it for $0.015. And we just don't think that way yet.
Thanks. Ken, if the U.S. healthcare industry is an industry driving to standardization, accepted evidence-based best practices, and narrowed variation on costs and clinical outcomes, then where's the room for innovation? Which I thought was an interesting paradox. So it's a two-part question. If we're all going to be, and if we all end up doing things the same way, who's really going to be the innovators? Here's the loaded part of the question. Can you really manage innovation? You know, we see a lot of health systems around the country building their innovation centers. Is innovation something that really is there to be managed?
Yeah, that's like a three-part question. Do I get paid extra for that, Dan?
You do.
Okay.
You do.
Vern's in here in the audience somewhere. He can do the statistics on this. It wasn't one question. You know, this question about standardization, that's a part of our future. If you're running a hospital or a clinic or anything in healthcare, we've been a cottage industry for, you know, our entire existence. That will come to an end. I was literally with a group of orthopedic surgeons the other day, and I won't name the name. No, they're not related to you, Bobby. They owned their own surgery center, and they were bragging about how well they were doing with their surgery center. Some of the Atlanta people have probably heard me tell this story. And they were talking about how well they're doing, and I stopped the president of the group. I said, well, how do you do so well with this? And he said, well, for example, for hip implants, we only offer one option to patients. One. They do 500 to 1,000 hip implants in the surgery center every year. And I said, okay, do you know how many you require us to offer at Mercy or Unity Hospital or Abbott? Anybody want to guess? 13 different hip implants. That costs us an additional 30% cost to offer all these different varieties, train all the different staff on different implants, have all the sales reps, all the contracts, all the relationships. If those orthopedic surgeons can standardize to one implant, so can we. And I will tell you, ultimately, we are going to have to. So we will be driving down this road of standardization. It will be significant. The other thing I would tell you is I was with the president of 3M about 2 weeks ago. And I was asking him, kind of just off the cuff, we were with 20 CEOs from around the country and the 3M leader. And I said, so what's your view of healthcare and how we operate? He said, do you really want to know? I said, yeah, just give it to us straight. He said, you guys are in the dark ages. You operate like an old cottage industry that everybody does their own thing, and there's no consistency, no standardization, no systemness, no discipline. You really don't operate the way we operate our manufacturing plants. And when you can figure out to operate like us, then you will save serious dollars, and quality will improve dramatically. And you know what? He's right. We still run our hospitals, and we run them very well, relatively speaking, but compared to every other industry, we are way behind. So this question about innovation, it's a tricky one. For the Atlanta folks that are here, you know I'm one of the cheapest guys in the world. I really am. The only reason I got this beer was it was free, and it said Finnegan on it. Dean, wherever you are, Dean, that's the only reason I got that. My general reaction to cost reduction is we need to be less expensive. Take the chassis cost down. We can't afford to invest in innovation. So that's my knee-jerk reaction to that question. Now that said, I actually think innovation's the part of every leader's job description in our organization, and I don't think it should be outsourced. And that's coming from a guy that outsourced it at Allina. So we created a Center for Innovation, and we thought we could move it into this separate bucket and fund it, and I think that's all good, but I actually don't think that's right. I think it should be integrated into the organization. Leaders should be expected to innovate around standardization, discipline, how do you operate, all the things that you mentioned, Dan, and be part of the job of that individual rather than sent off to some place where they're going to be in a think tank and come up with creative ideas. So I'm one that believes in innovation. I think you have to basically fund it through your existing operation, not create a separate think tank where you're funding it outside.
Let me just give an example that happened today, and it's a small example, and then I'll give a little bit larger one. But I was talking at the professional affairs meeting this morning. Some of my obstetrician physicians were saying how they were concerned because a lot of these young mothers working and the kind of hours they're keeping, they're not getting to prenatal classes, not learning how to breastfeed their first child. They're not learning how to make the delivery easier, and so they're not getting the classes, and it's like, how do we do this? And then they told me about a couple of our nurses that came up with an idea of putting a prenatal class and breastfeeding class on the internet so that all these young mothers, they're going to be told about it when they come to the OB's office, and they'll say, if you're working, you're busy with your kids, you can go on after the kids are to bed or after you get home from work, and you can, for first-time mothers, you can access this anytime you want. That's just a small little example, but to me that was an idea because we all know that learning how to breastfeed properly, prenatal classes are very important, but there is an increasing incident of young women not getting to the classes because they couldn't get there or it was after work. Another example is some of our physicians, we invest all this money in electronic medical record, and they're really getting into and getting excited about how to extract, very innovative on how to extract data. They have to input the data like high blood pressure into a discrete field, but then they can pull that data off of every single patient very quickly, very easily, and learn how to manage high blood pressure on a given population or even who has it. So, I could go on and all of the ways that they're learning to use the electronic medical record to develop standards of care, protocols of care that are based on evidence. And that's innovative to me. That's innovative. It's resulting in better patient care.
Switching gears again, Bobby, those leading academic medical centers interviewed expressed concerns over the future of healthcare economics and financing in a reforming marketplace. Some question their ability to continue academic health center missions if healthcare costs and payments are pressured as expected. Many question whether the integrated teaching, research, clinical care model of academic health centers can actually remain financially viable. Your thoughts and answers to the obvious challenges. How do we finance graduate medical education and research? If not on the back of the economics of healthcare delivery, what do we do?
Hard question. Well, I think as many of you know, graduate medical education right now is funded by a combination of support from Medicare as well as support from health systems and physician practices. And all three of those revenue streams are going to be subject to shrinkage over the next few years. And so like is occurring in other parts of the healthcare environment, we collectively need to figure out how to do more with less, and also to figure out how to eliminate the redundancy in the process of graduate medical education. So by starting with the patient, as Ken mentioned in terms of how healthcare reform hasn't started with the patient, reform of graduate medical education needs to start with the patient at the core. And I think we need to determine what the right workforce is. Not the right workforce in the way it's been determined before, but the right workforce to deliver the outcomes that the patient needs. I think there will be a declining emphasis about the proportion of that care that's delivered by physicians trained through expensive medical education programs, and a greater percentage delivered by nurse practitioners and other providers in the healthcare spectrum who actually do a better job than physicians at providing much of the care that our patients need. So if we first then think about how we change who we need for the future, then we also need to think about how the training occurs. And I think the medical education process, and I'll speak mostly about the physician medical education process, is actually very long and largely redundant. Someone might take biochemistry several times. So there are multiple opportunities to shorten the length of time it takes to get from an undergraduate program through medical school, and also there's significant overlap between medical school and a lot of the graduate education programs. So I think it will be a combination of reducing the redundancy in education as well as changing how we deliver care and developing the workforce that allows us to do that.
Other responses from the panel on graduate medical education and funding research and education, kind of on the back of a very competitive community healthcare environment, which frankly we have here in the Twin Cities.
Yeah, we have no policy basically for the future, and as Bobby pointed out, the historical sources are going away. I think there are a couple related challenges, though, that should be noted. Is if you look at the clinical side of academic medical centers, they're moving more consistent with the pace of change in community hospitals in the delivery of clinical care, but medical schools aren't changing at the same pace as the clinical side, so the mismatch between them is becoming greater, and there are greater strains because of it. And the other part that clearly academic medicine wants the patients to come to them, and some of the people we interviewed, clearly that was their model. But if you look at it, we're now distributing under clinical trial science awards, CTSAs, we're distributing research. It's not going to be long before we're going to have to distribute clinical education over the clinical systems that we're building, but we have no models that are existing in the country to do that. But that's coming.
Catherine, if under a reformed healthcare marketplace, if everyone is actually covered by some sort of insurance or insurance look-alike, do you think we really need safety net hospitals in the future that receive all the add-on payments? And friends I have that run them say, absent those add-on payments, we wouldn't be making it. So if everybody's covered in the future reformed marketplace, do we still need safety net hospitals?
I think the predictions that, I don't have the exact number, but even through reform, we anticipate somewhere about 23 million uninsured patients. And I think one of the concerning things when you look at reform is for the ramp up to get insurance in a pretty complicated way of getting that, although access is improved and the rules are relaxed in some cases and universal coverage, the ability to get that and to understand that and to use that is still complex. And the ramp-up period for that versus the ramp-down period for the extra safety net payment, I don't think they're aligned today. So my answer would be yes. I think we'll still need that.
Reactions from other panelists. Safety net hospitals, yes, no?
Well, just a real quick thought. One is that if everyone is paid at the same level, universal coverage, I think, Dan, was your question, and paid the same, then the question becomes, is that payment sufficient to cover the cost? And we clearly know the feds aren't sympathetic to covering duplicative cost structures, and so if if healthcare needs to hit certain cost targets and everybody's paid the same, then in essence, but I think Catherine raises an interesting point. I guess 20 million people, still people floating around. What I thought was the reaction would be that critical access hospitals, I believe, extra funding for critical access hospitals would still be needed because there's a lot of places out in the boondocks that can't get access to an emergency room in any kind of a timely manner, and a metropolitan area is too far. So I think we'll always need critical access hospitals and special funding for that. My first reaction when I saw that question was that if everyone's paid the same and it's covering some targeted cost, you probably wouldn't need the volume of safety net hospitals. But if clearly we have in large metro areas still a lot of uninsured run around, then we would.
So, just to be a little provocative on this question, I'd say maybe the answer is no. That we don't need, I don't know if safety net hospitals is the right way to put it, but do we need the same number of hospitals that we've got today? Do we need the same number of beds that we've got today?
That's a different question.
It is a different question, but you know how these debates go. You can answer any question you want, right?
Very good. Got it.
And it's true. We'll see that tonight. If we've got this huge oversupply, and maybe we do, then we're going to have to do some things differently, and consolidation may be an opportunity to take out some hospitals that were traditional, either safety net or other, and have them combined to get a different look at what the system should look like. We just can't fall into the trap of taking our current system and assuming that we're going to deliver the future model with that old system. It's a little bit of what you said around the care model. If we get stuck in that construct, then we got what we got, and we're going to try to make it work, and we've got too many of the old things that aren't good for the new world.
Then we ought to be talking about how we are in the community relative to primary care, and how, because those emergency rooms are the safety net, right? So it's, how do we prevent those beds from even getting utilized, and putting it outside of the context of a hospital in total?
I think that's right. I mean, just think how much care we could provide if the half of the patients that go to the emergency department today don't go there, and they go to an urgent care facility or a primary care office or something else. There's just so many opportunities to think very differently about the structure, that if we don't start there, then we will just back ourselves into, well, let's use what we've got, and what we've got isn't the future. It's just not the right answer long term. So I guess my answer to the safety net question was, I'm not really sure if that's the right approach, and maybe some fairly bold moves in terms of eliminating capacity might be a good thing.
Well, I think this question really hides a more difficult question, because I think we're going to have access for those who don't have coverage, and we kind of back into it today. But if you look at what happened in Massachusetts, if you look at the data from Tufts, when the program went in, their bad debts went up more than their uncompensated care went down. So the net on covering everyone was actually a 1% reduction in total revenues. So the real issue is, how do we survive as a delivery system when our average payment levels are going to be Medicare minus?
Or lower.
That's where we're headed, Medicare minus.
Yeah,
Right.
lower. Yeah.
I'm going to direct this question to...
I was just trying to make everybody feel good.
Good.
Yeah.
That's why we're here tonight. How are we doing so far? I'd like to pose this question to Howard because of your vantage point on the marketplace. Few surveyed disagreed with the premise that not-for-profit status could be at risk, especially as new types of financial partnerships are formed, more people are covered, basically the marketplace landscape changes. What do you think, and does it really matter? Can health systems that are traditionally the not-for-profit tax exempts exist without a tax exemption, and what role does it have in a reformed marketplace?
Well, we already see it, and I already use Massachusetts, but whether it is taxes or it's some kind of payment in lieu of taxes, you have so many communities where the hospital is the largest employer, and you've got coverage of whatever governmental services are being pushed down from the federal level to the state level to the local level to out of existence. And so sources of revenue are clearly going to be there. And regardless of what our payment levels are, if things are paid for, the primary reason that hospitals have argued for their charitable status has been access for uncompensated care. And so I think it's likely, and if you look at practically and you compare the behaviors of, I don't know who is here from Ascension, but if you look at Ascension and what it's engaged in, and you look at the real differences between proprietary organizations and nonprofits, it's diminishing very substantially. And as we become more concentrated, the differences are going to become small.
Anybody else like to take a position? The position of some of the folk we surveyed was, I think it could be at risk. Everybody's covered. Why do we need it? Does it go away? Does it stay? Is it useful? What do you think?
I think our behavior has been, inviting this conversation, and it is sad that we are the largest employer typically in our community. And I think the other thing that's going to continue this discussion is going to be around access to capital. So we see a lot of health systems going to venture capital, and I think Aurora Health System just announced its affiliate, its partnership, if you will, around a cancer center. So I think that's going to keep that conversation going, and to the extent that that's how we act in terms of duplication, competition, I think our communities have no choice but to ask for that.
And I think that point's well taken, and it goes to some of the responses, and that response is, as health systems try to get creative or innovative in a marketplace, find new partners, find new capital partners, start to behave differently, why should we as taxpayers be supporting that with a special exemption? And that's the question.
Dan, I got to tell you, I disagree with that. We're at a time when we will see more change in healthcare than probably our entire careers. 30 years of doing this. This is the most dynamic time for change. We will have to try new things, subsidize the change from fee-for-service to capitation, come up with new ways to train doctors, do research, bring the lab out to the community, connect with communities in a completely different way. I don't think that's the time to think about a change to a for-profit system. I think that's when you want to maintain your mission orientation in the nonprofit structure so that we can do these things with a little bit less risk. Once we get to a for-profit structure and it's taxable and whatnot, I think we then lose the focus of why we're really here. So I would hope that during this very dynamic transition, that's the time where we want to have a fairly stable nonprofit platform so we can try some new things and do some things differently. It doesn't mean that we shouldn't perform better, but I'd hate to hamstring us at this time.
My argument is not in favor of proprietaries. My argument is that if you're going to have a preserved charitable purpose, you got to figure out what that purpose is, and that purpose is diminishing in the changes we're going through. That's all.
Just a
Well,
couple.
but there are two elements, two different reasons why organizations can have a tax-exempt status. So one is truly to provide charitable care. The other is to support the research and education mission. So maybe the answer to my earlier question is that people would rally behind that as a reason for tax-exempt status in addition to the charitable vehicles that people use now.
Just a couple of quick tidbits of information. Right now, we have estimated that we give 6 times the amount of charity care that we'd have to pay in income taxes on our net revenues. Secondly, we're in 26 communities, and we pay significant tens of millions of dollars of property taxes on all of our outpatient facilities, whether they be hospital without beds, satellite emergency rooms, et cetera. So we're paying in some of those communities we're the largest property taxpayer already. I think that the issue comes down to what Catherine's saying. If we're really going to, the for-profits, the proprietaries, the only thing they really have to comply with is EMTALA, right? They stabilize a patient, can send them out to one of our hospitals. And so if everyone's covered, but if we still have people that are uninsured, we better have some organizations around that are still going to take anybody that walks into their ERs or into their doctor's offices.
Oh, I'd also say, Dan, are you facilitating or am I doing that?
Please.
No, I'm just kidding. No.
The floor is yours.
Okay. I think we have to ask the question, what does society need from us? Society needs lower healthcare costs at a higher quality, output or outcome. That's much more important for us to deliver than X% taxes on whatever we do. I got to tell you, it trumps that question for me. So if we should lay pressure onto the system, we ought to lay pressure on the outcomes that we produce and go after that. There's so many opportunities. There's plenty of low-hanging fruit. That's much more important than taxing nonprofits.
Next question, Bobby. Leaders interviewed reported the need for retooling their organizations to take on more financial risk, to be accountable care organizations, to enter into new kinds of financial deals, ever more exotic. And at the same time, there seemed to be a nagging concern by those interviewed of being too far ahead of a market. In other words, getting all dressed up for no place to go. You lead a very special organization in this community relative to the missions of clinical care, teaching, and research. So you have an interesting perspective on the marketplace. Does your organization run the risk of getting too far ahead of this curve, and do you see other organizations in the community getting out too far ahead of the curve?
Well, I think that's definitely a risk as we're in this transition zone. And I think we've seen it in the past, as in the 1990s when there was a movement from fee-to-service to greater capitation. Then after that, there was the move from capitation back to fee-for-service. And each of those times, the winners were those who could adjust the quickest. And getting out too far in advance of the market, I think, is problematic. So it does take walking a very fine line and being innovative not just with how the care is delivered, but how one is able to negotiate with payers for a different type of incentive and different payer mechanisms. I think as it relates to research and education, I think on the education front, we are not ahead of the market. We are unfortunately behind the market. Those of you who are hiring new physicians know that. And I think what we need to do, at least from the university perspective, is do a better job of meeting the needs of the future employers of all of our trainees. And so that's something that I think we could accelerate and serve the community a lot better. But it's a very tight line to walk, and I think we all know of organizations that have, during those various cycles in the past, gotten too far ahead or not been reactive enough.
I saw this film play out several years ago in my career where a number of people got all dressed up for marketplaces that didn't show up. So I'm personally concerned about that, so I appreciate your
but
response.
it depends upon what you're getting dressed for, doesn't it? So if it's to play a game, then you can't possibly predict that future. If it's to create value that is able to fit multiple scenarios, then I'd say we can't start soon enough.
Is there a risk, and well said, is there a risk that health systems get ready, but the payment system isn't there fast enough?
I think that there's probably enough waste in the system that if we could simultaneously learn how to take better care of patients and reduce the cycle time that it takes to have patients get their services, take out all the different kinds of waste while we're taking better care of them, then I think there's enough waste to make up for that. So I have a strong opinion that we need to be getting ready now.
Do you think the payers in this town, from what you've seen so far, are moving fast enough for the change in the health systems that you're seeing?
I think they're in step with the provider systems, both being tentative, with the exception where there might be something like a partners that or a park that have worked together are like-minded.
Dan, if I could just jump in with a novel thought, maybe, at least novel to me. Instead of, healthcare administrators reacting, we call it management by modern healthcare. I mean, 20 years ago, those of you that were around know that we were supposed to be 100% capitated today. And I think I may have, I don't know what percent capitation you guys have, but our total business out of 1.2 billion, 20% is fully capitated. And it's a little bit what Catherine was saying, what are you dressing up for? I did this thing like Dornblaser taught me, I don't want to say how many years ago, but I sat down 23 years ago when I went to Mercy, and I said, how should healthcare be delivered? Is healthcare more efficient when physicians and hospitals get on the same page, become part of the same organization? Yes. I mean, it's just, and I had spent years at Mayo and at the Mason Clinic, Virginia Mason Hospital in Seattle. And so I said, well, that's what we're going to do. We're going to develop a W-2 physician partnership model where those doctors that want to, join in with us can join in. I still love all the other physicians. We're going to treat them all equally. They're all members of the medical staff. But for those guys that want to come in, then I can now legally help market their practices. I can help do things that I can't do for the physicians that stayed outside. And that train just kept moving down the tracks in an evolutionary way. And more doctors got on board. And I was in an environment where our entire medical staff was organized in 2 large multi-specialty clinics that had about the equal size of Mercy's balance sheet. And I had to grab the hospital out of the jaws of one of them that was ready to take the hospital over under their balance sheet. That's a much tougher scenario than in environments where you've got physicians that are organized in groups of 2 and 3 and 4 and 5 and 10 and 1 and 2. There it's like, let's put the right model in place and let those doctors join us that want to, and we continue to love all the other members of our medical staff. Should we begin to learn how to manage care to get ready for capitation? Let's start to begin how to really engage physicians. And I don't mean put donuts in a medical staff lounge, but I mean to really work with them as partners in learning how to manage care. So we started this process and we just kept moving along. And I guess I didn't know that 23 years ago what we were building was the basis that what is today probably one of the more sophisticated accountable care organizations in the country. But to me, it was the way healthcare should be delivered, both for the greatest quality and the greatest cost effectiveness. And so I really don't care what kind of dance ends up being developed. I'm ready to go to any dance that that comes along. But I'm a firm believer that it begins in the healthcare. Patient care begins in the physician's office, and if we're not working as true partners day in and day out with physicians, and we're both aligned 100%, then we're leaving a lot of good quality and a lot of cost effectiveness on the table.
By the way, given the donuts comment, my class Monday for my students is canceled. That was the topic, by the way. It was supposed to be funnier than it was.
Let me add one thing. I don't know how much time, but I don't think we're getting to the future by the prescription of the federal government. I don't think that what we're talking about now, the language, the time periods to get the bundled payments, all of those things are going to drive change. There's real change happening with the providers, and the insurers may be more enlightened in Minneapolis than they are elsewhere, but generally the view that I see is the insurers are more reluctant to change than the providers are because they're dependent on their historical financial structures and IT structures, and the change is going to come from the providers. And if we're waiting for somebody to give us a regulation or a plan, that's just not how it's going to happen. It's going to happen by the good work of the people in this room.
Ken, your predecessor made some significant shifts to the governance structure in Allina. Many of those surveyed questioned their current government or governance model. Some are looking to less community representation and more competency-based boards. Second, consolidating control with a senior board and really questioning the utility of community boards for multiple hospitals across their systems. And third, including more insiders, meaning physicians and management, employed physicians and management on the governance structure. What do you see for governance for Allina?
Yeah, if you don't know what Dan's referring to, Dick Pettengill was my predecessor, and he took 11 hospitals that had independent boards and eliminated the boards and created one board of trustees for Allina that's got roughly 15 members on it. And I will tell you that we couldn't operate today the way we operate if that didn't happen. And I'm really glad he did it and I didn't have to do it. It was very political. He almost lost his job over it. It was the right thing to do. And I say that for a couple of reasons. One is, to the consolidation point that was made earlier, it's quite possible that in each community we'll have 3 or 4 big, major, very well-organized healthcare systems. And we will go at each other around performance, quality, value, cost, whatever you want to call it. We'll manage risk, and we will have to drive very efficient, well-run organizations. You can't do that with a distributed board with 11 different boards. You just can't do it. So I would say it was critical to our place in the market today. We have moved to more of a competency-based system, although we do believe having independent directors is very, very important. You do need this check and balance with management, so it's not an insider game. I think they provide great value to us. And we've brought the kinds of trustees on our board are running big corporations. CEO Caribou Coffee, the CEO of Allianz, the CEO of Buffalo Wild Wings, several bank leaders. They're really good, they're really dedicated, and they hold us accountable. So I would say we need to run like a big company that's very disciplined and very focused and very integrated. And I'd say he made all the right moves.
Other folks' perspectives on governance of health systems.
One of the smartest things I did 23 years ago was having about 30% of our board be healthcare experts. You know, as I said at this Hamilton Society last year, I was fortunate enough to have and to remember Stan Nelson is one of my first expert board members, but I had 2 others on at the same time as Stan, and I despite the fact that Stan always said that, I just wanted him to nod his head as he slept, because he'd always get bored with my presentations and he'd doze off. And but my board took that as affirmation that he was agreeing with me. And but the fact of the matter is, I put him on because I really wanted them to challenge me, and it was the greatest thing I ever did, and we still do it to this day. 2.5 decades later, we have at least 2 to 3 healthcare experts on the board. And that has really served us well. And then we've did the same thing. We have one system board, and we have a few operating boards, one over the insurance company and so forth, but they're made up of, the system board is made up of members that are all on the operating board. So tight vertical integration between a few of our operating boards and our system board.
Just to keep up a contrary view a little bit, one of the interviewees that I had time to spend with, and I won't say who it is, made the argument that we spend entirely too much time getting ready for our monthly board meetings, and that if you look at the model that he operates, that's a very large organization, it's based upon management competence, and the board is responsible for periodic review. They can fire the management if they want, but the management sees the imperative to move and get things done and not spend the kind of time we spend in many organizations preparing for monthly meetings and reports.
Bobby, many interviewed held the opinion that the graduate training programs, and this was management graduate training programs, are not teaching to required competencies for the healthcare delivery challenges ahead. You have an interesting vantage point. You lead a very large organization. You're a practicing physician. You're involved in teaching and research. So this begs an important question, certainly for our program, for our faculty, and for our alums. What sorts of competencies would you want to see folks like us teaching as you hire these folks coming into a very complex organization like yours?
I don't know that it's possible to prepare for specific tasks and skills, The smarter someone is, the more creative that they can think and the more willing they are to approach problems, I think the better they'll do in an organization like ours or many of those represented here at the table. I honestly don't know how that's taught. There clearly has to be a high bar to get into the program, and then there does have to be some amount of competency afterwards. The other, or competency taught afterwards. The other piece of this, and I actually learned this, or not really learned it, but the point was struck to me when I attended freshman orientation for my son, and he went to a college on the West Coast. And the university president got up in front of us at the beginning, and all these kids were bright kids, and the university president said, if you don't fail during your 4 years here, you haven't tried hard enough. You haven't extended yourself. You haven't challenged yourself. And I think we as educators, whether it's in an MHA program, whether it's in the 4 years of medical school, whether it's challenging students in their residencies and fellowships to get outside of their comfort zone, I think that needs to be an increasing emphasis in the university training programs. And I think we should probably expect that more of ourselves as well. The fear of failure, I think, allows people, or encourages people when they get into an environment like we're facing in healthcare to not reach far enough and be bold enough.
So
Others, what should we teach?
I've got a real specific suggestion, and that is I don't think we teach our MHAs how to think enough like physicians think, or how physicians are educated, and the process that goes into and the thinking process that results from a medical training. There's a big difference in training an MHA and MBA. We train them to plan their work out and work their plan. Physicians really work in a very now environment. I could go on. I've got a big comparison, but we don't do a good enough job with our. We've had 36, 37 fellows, and that's the biggest thing that I see lacking, and one of the biggest attributes they pick up during their year at Mercy is really what I call Zen, Z-E-N, Zen management. The whole concept of the idea of servant leadership, of how to lead physicians, manage physicians without them really know they're being managed. And and in order to teach our MHAs how to manage physicians without the physicians know they're being managed, because we have 400 physicians that we need our MHAs to manage without them know, is you have to teach them how the physicians are taught to think. And so there's a big gap there. And I don't want to, but that's something I think you could have a whole course around. And I think that Ted Littman, years ago, had a course where he brought, Wade Miller in for one, me in for one, several others that had a lot of physicians on their staff. And I have to think that at the end of that quarter, that those MHAs that I talked to were starting to get a concept of how doctors are taught to think, and then thus how to manage them.
So
Catherine, Ken?
that scares me to death.
Why?
To think that we would have a course to talk about physicians. I mean, if we want to talk about how we all, as human beings with different expertise, can talk about what our roles are and how we can collaborate, then I would say yes. And I think physicians need to learn that as much as CEOs need to learn how to collaborate. But you're all smart, and you're all going to go on to great careers. And pigeonholing a group of people, I don't think will serve us best into the future, because it cements that role.
Yeah, that was just one. What I was trying to say was, I said one specific thing. If somebody's going to, I don't know where you can work in the healthcare field unless you're in a policy role. that you're not interacting with doctors. I'm just giving you my experience.
I understand, and I'm just saying I
experience.
disagree with that because
That's
I think
okay.
it pigeonholes and it cements a non-collaborative relationship.
She thought I was him. So.
Okay.
So you know what they teach in medical school? How to deal with administrators. How to deal with administrators, that's right.
Right.
So I have one. I think if you look at how our organizations actually run, all due consideration to everyone that's here, but we invest too little in developing our first line management, and we don't have the kind of skills that we need to develop those that work with us so that they can do better than we do and make us look good. And we really need to invest a great deal more in that skill set.
I would say, Dan, just to be very specific, the problem-solving skills from the MHA program, critical today. Is Dorn here by chance? Right here. Where? I mean, I can tell you I still use those processes today. Not every step, not all 14, Dorn, but I use a lot of them. That's a critical skill for us. Second, what I would call kind of analytical ability, and kind of what Vern taught us, and not to trust the data that somebody's giving you, to dig in a little bit further and find out what's really there. Is Vern here tonight? Vern, where are you? You're not smoking tonight, are you, Vern? I think third, what would be really important is process improvement. We've got to take this huge monolith of a very complicated, bureaucratic, inefficient system. We've got to hammer it into something that's a streamlined, very efficient organization, and we need people to help us with process improvement. And the last thing I would say, and we've found this from the MHA students that we've hired, you need to have fire in your belly for this. You really got to want to make a difference. And because you will get knocked down constantly by administrators, by doctors, by patients, by you name it. We need people with passion that really want to be a part of the solution. There's so many opportunities to fix this thing.
So I would just put a big second in for the process improvement. It's a great place to start after an MHA.
This question for the panel. We have just a handful left, and I want to open it up. This is in part, this survey, in part the one that I have ongoing. And I asked this question to CFOs of health systems around the country, and I've asked it 27 times so far. And the question goes like this. What do you think you need as a profit margin on your largest commercial payer to compensate for your operating deficits on the governmentals? That's the question. Everybody understand the question?
Yeah.
The range I get gets tighter and tighter, but the range I get from CFOs is 36 to 42%. Somebody's getting a lot of cost shifted to them. If we're in real reforming marketplace where the economics become compressed potentially to one single point, which is theoretical at the moment, who are you going to shift the costs to?
I would say, Dan, we got to get to break even for Medicare. And we lose money every day in every Medicare patient we see. So break even for Medicare. If we get to that, and we're not there yet, we have to cut about 10% of costs at Alina to get to break even. Then I think the number's much smaller for a transfer of payment, cost shifting. I think it's more in the range of 5 to 10% at the most. But we've got to get to break even with government payment because, quite frankly, that's where most of our patients are going to come from. We are going to be, by default, a government business. We're going to be 60% government.
So I think that's a good handle. I mean, a good, sort of rule of thumb. The IOM came out with a report September 6th about 30% being waste, and it's been my experience that that's probably low, but clearly a solid 30%. So we should not be cost shifting if we can get that waste out.
Actually, one CEO of one of the blues around the country was on a podium with me recently. He said, I actually had a CEO from a health system with a straight face asked me for a 35% price increase because I was the only payer that could fund his new bed tower. So we've still got that kind of mentality and behavior. And Ken's point is we're going to have to get to the governmental price point. Everybody else agree with that on the table?
Well, we already know that the Affordable Care Act has taken out over $700 billion out of Medicare, and the feedback that I get from the chairman of the House Budget Committee is that the price point that you're thinking of with Medicare isn't going to stay there. I mean, our reimbursement of what we get from Medicare today isn't going to look like that at all, regardless of who gets elected. So, I think the issue comes that when people want to simply rely on reimbursement to support the pluralistic cost structure that exists in the delivery system, it isn't going to happen. There's going to have to be more integration.
Just a couple.
This isn't a direct answer to that question, but it's what's on my mind. That
it's what?
What's on his mind?
No, I appreciate the accounting construct for that, but I'm going to take us back to innovation, because I didn't get to say what I wanted to say, that we just can't get to the future without doing things in a fundamentally different way, and we're all being driven by regulation and licensure and accreditation and piles of that to do everything the same. And until we start asking ourselves the question, how can we get outcomes that are fundamentally different and cost fundamentally less? It's not a ratio of costs to charges. It's the idea that we need to get an outcome, and we have to ask ourselves, how do we get that outcome in a fundamentally different way than we do it today? Because if we don't do that, many of the organizations we know are going to fail. There's not enough money. They're just plain old going to fail. Critical access hospitals, certainly. So we really have to hammer that. The accounting is for the short term, the change is for the long term.
So in light of the issue of change, let me pretend for a moment that I'm your board chair. And I buy all this stuff about transformational change, and I believe you. You're all smart people. You're running big organizations. But the way I see it, we've got balance sheet pressures. We've got downward pressures on revenue. Our liquidity is sinking like a rock. Revenue is dropping. I want you to transform your organizations, and I want you to stay profitable along the way. How are you going to do it?
Well, it's a perfect question because it lets me answer my reform answer. That if you look at it, and I won't tell you who the organization is, but our biggest problem is changing the culture of the organizations that we run. And as long as we're running under two different methodologies, we're just never going to get there. In my view, if we had spent the money in reform to fund the transition, ultimately covering everybody but paying the transition, that would have been better, because the small community hospital doesn't have enough margin to fund the transition. So they're either going to consolidate or fail, and we simply we have to figure out how to get from here to there, and we've got to stop believing that if we all do everything exactly the same, that somehow will lead us to quality. We need to figure out 4 things that are really important and allow this industry to start to think in a creative way about how we do it.
Okay, well, I get that as your board chair, but can you transform this place and keep us profitable quarter to quarter or not?
Well, the answer I got from one organization was this, and it was a large organization, and what the CEO told me was that this year we've decided that we're going to lose $40 million on purpose, because if we make that money, we're going to continue to reinforce the behaviors that we have in the organization, and what I have to do is run to get my capitation business over 50% so I can have a culture that operates in that way. Most organizations can't do that, and that's why I expressed that view of funding the transition of the cultures.
Other CEOs on the table.
Yeah, I
mean,
we
profitable and
we did it, right? So for 23 years, we have made a profit every quarter for 23 years, and we went from a $33 million hospital that was losing when I took it over. We're at $1.2 billion, 400 multi-specialty employed physicians in 69 locations in 26 communities. 18% full capitation, are a wholly owned and operated insurance company, and we were profitable every quarter. How did we do it? We started and we just kept going each quarter by quarter in an evolutionary way. Again, what I saw from the surveys that Howard sent me, the responses, management by healthcare. I wait until it's done to me, or I feel like my back is up against the wall. I'm not going to read the handwriting on the wall until my back is up against the wall. And then oftentimes it's too late. This Affordable Care Act, no matter who gets elected, is going to take many years to fully roll out. And you begin today, and whether it's 3 years from now before it's full capitation and more reimbursements on value-based reimbursement, whether it's 3 years, 8 years, 12 years, you begin today and you're going to be 3 years further down the pike, 8 years further down the pike, 12 years further down the pike. But can it be done? The answer is yes.
So I'd agree with you. We need to start now. Right? But I think in Health Affairs in September, Helen Darling talked about this, and that it's not going to be enough to have all of these other pieces. You're going to have to fundamentally take a look at your organization and figure out how to take out all of the extra waste. With all of the other things, with incentive payments and total cost of care, all of those things are important and may or may not come fast enough. But I do agree with you that you got to start now.
So relative to that, and the point well taken, so for all the CEOs, sort of the tough issues keeping you up late at night, the 2 or 3 big issues that you just wrestle with all the time.
I can say that there are a couple. The one I referenced already, it's this capacity question, that we have so much stuff in healthcare. And I just can't imagine a world where we're going to need it, going forward in a constrained environment. So I do worry a lot about that. The second big worry I would have is that we do have to get to a different incentive system. There's no way we're taking costs out until we actually have risk for it. And I've been doing it for 30 years, and we've always taken a fee-for-service approach, and we make it up in volume. You've heard that line before, and we're good at it. So we've got to transition to some form of risk, and that's not easy. I would say the third thing is somewhere in this we need the patient engaged with us. And the reason I think risk didn't work the last time we did in the 90s, the patients weren't engaged. They weren't part of the solution. So I do worry that government, quote, whoever that is, will pass risk on to delivery systems, and patients will be left behind thinking that it's the old system, and it's not. And I'd say up until now we've been somewhat complicit in the obesity issues and smoking issues and lifestyle issues in this country as healthcare providers. We haven't taken them on because the patients aren't engaged. So those 3 things I spin around in my head constantly and try to figure out how do we get there dealing with this. And we've got some tough, pithy problems, and those are societal problems that we're going to have to deal with.
The rest of you, the top 2 or 3 that...
Yeah, I only have one thing that keeps me up at night, but I do want to make a comment. I don't know how to, our biggest growth area is in Illinois, and the last 2 governors, are in jail, and they have it's how to deal with the corruption in the state of Illinois and get our new hospitals approved under the C1 without me going to jail. I've already been investigated once by the FBI, and so it's how to deal in that state of corruption. That's the only thing that keeps me up. The other, the real issue, though, I think, is that the Affordable Care Act does nothing with the individual. And I was just talking to one of my board members this morning who is an insurance expert in healthcare insurance, and he was citing to me, it was very interesting, he was citing me studies that show that positive incentives do not work with individuals, but negative incentives do. So in other words, he's got all these insurance, all these employers, and he said the employers who say, if you don't get your health physical, you're going to, and give a report on it, your premium is going to go up $25 a month. And based on your health assessment, we want to see X targets, X weight loss, smoking loss, or your premium will go up another $25 a month. he said the employers that put in those kind of incentives, don't shoot the messenger, I'm just saying that the employers that put in those kind of incentives get much more success with their employees and change of these lifestyle issues, these negative lifestyle issues, than positive incentives. So whether they're positive or negative, there are no incentives built in to the Affordable Care Act whatsoever. And that's going to be a real issue when you talk about, we're going to pay you less, bundled payments, and you need to take care of people, and you got to meet quality standards and all these health targets, and yet there's nothing in there, in that universal payment, to really motivate the individual to change their lifestyle.
We hear all the time about how bad the healthcare system is. But if you actually, look at where you might want to get care when you're really sick, we actually we have a remarkable system. It costs too much, it's not coordinated, but it's remarkable. And, my greatest concern is that we will micromanage our way into a much less good system rather than coming up with a way to finance populations and really unleash really true innovation. And we're kind of at that dividing point where we're either going to go down the, well, everybody should do it this way path, or we're going to unleash innovation.
Last question for the evening, and then we'll move on to a different type of debate. Open to the panel. Virtually every leader interviewed is moving the organization along a path to higher levels of physician integration, namely employment. How does the private practice factor into your health system's future?
We love them.
You love them?
Yeah, I love all my doctors. And so we're in different hospitals, and whether they're employed or not, I love them all, and I'm welcome to have them on the medical staff. And so the point is, legally, the ones that are part of the health system, what we call the W-2 physician partnership model, I can legally do things for that I cannot do for the medical staff, physicians who are not part of the health system. That's just a fact of life and legalities. But I love all my doctors the same when they cross the threshold of one of our hospitals, whether they're part of Mercy or not. Just let me give you one practical example. So we have Mercy employed surgeons and we have non-Mercy employed surgeons. Our Mercy employed surgeons don't get preferential operating room time. It's based on volume or whatever, objective criteria. So I love all my doctors, Dan.
How does it factor in the other health system's future? Bobby, you have a much different model.
Well, we do. So University of Minnesota Physicians is about 800 physicians, and we basically partner with all of the health systems in town. We have one predominant partner, Fairview, but we are a private practice, and probably the largest private practice, I guess it would be in the state. And maintaining that separateness is really important for us. But with each of our hospital partners, we have a significant amount of integration. And so I think the important issue isn't, is a physician group private practice or employed or whatever. I think the message has to be that physicians and the all other parts of the health system have got to work together. I mean, we will never get to the type of health system that will keep us healthy into our 80s and 90s if there is divisiveness between physicians and other parts of the leadership. And I think, although it may not have come out here, there are times when physicians as the leaders might be important. There's times when MHA grads as the leaders is important. And I think collaboration ultimately has to be where we all end up, regardless of where you get your check from, which is what I always tell our docs.
Catherine, Ken?
So I think we've spent the last 15 years spending a lot of time and money trying a lot of different models along the continuum, and consultants made a lot of money showing us the way with those models. And I think through it all, that no matter what that model was, what I found is that if the physicians and the health team truly collaborated, it was about that behavior relative to how the patient was treated that made the difference. So I've worked at as administrator at Geisinger in a totally employed model. At Theta Care, it was a mixed model, and Health East is also a mixed model. And it didn't make any difference in those settings. What made a difference was showing up at the table and being open to being influenced about how we collaboratively took care of patients. So I would agree with Bobby.
Yeah, I can't disagree with anybody's comments here. I would just say that if you're a student getting into this profession, one of the great things about this job is working with doctors. And I will tell you, they're brilliant. They're the best students that came through college. They're very opinionated. They also hold the keys to our future. So if you want to fix healthcare, you can sit down with a doctor and ask him or her, well, how do you think we should do this? And most likely they kind of know. I'm also with Catherine on this mixed model. We have very much a mixed model at Alina, but we've got to get integration at the end of the day. So even if you're independent, you've got to drive and deliver value now. The market won't wait any longer for the fragmentation and the frictional costs of independence. So while you can stay independent, you've got to create integration value. And I actually don't think you have to employ somebody to get there. But again, I would tell you, if you're getting into this profession or if you're new to it, it is the ultimate challenge, but it's the ultimate opportunity to work with very, very smart, dedicated people. And quite frankly, what 99% of them really only care about their patients. That's their number one driver.
So I'm going to take prerogative of the podium and bring this to a close by thanking the panelists. It was very kind of you. This wasn't easy to do. You all had other places to be. And as I said, nobody turned us down for this. So on behalf of the program, faculty, staff, and our audience, I'd like to thank you. As I bring to a close, I'd also like to thank again staff, faculty, our Alumni Association for all its support, ACHE, who has been and is an important partner of ours. My partners in this endeavor, Howard and Jerry, thank you. Each one of our panelists will be provided a special gift from the Alumni Association. Thanks to the Alumni Association for that. And I want to especially thank our grads, our alum, and our friends for coming tonight on behalf of the Hamilton Symposium. So thank you very much.